Hello, everybody. I'm Dr. Steve Carstensen with Endodontic Practice US, a MedMark Media publication. Welcome to a live presentation and Q&A with Dr. Martin Trope. In our webinar today, we'll be exploring the latest generation of technologies that allows us to clinically obtain the essential biologic goals for endodontic treatment success. Before we get started, I'd like to invite viewers to use the question box in your control panel to ask any questions. Your questions will be answered at the end of the presentation. I'm pleased to introduce our guest for today, Dr. Martin Trope. Dr. Trope is a clinical professor, Department of Endodontics, School of Dental Medicine, University of Pennsylvania. He's also in private practice in Philadelphia, Pennsylvania. He's been awarded the J.B. Freeland Professorship in the Department of Endodontics at the University of North Carolina, Chapel Hill, School of Dentistry, and also the Jens Ove Andreasen Lifetime Achievement Award by the International Association of Dental Traumatology. I'm pleased to welcome Dr. Trope.
Thank you very much. I'm very pleased and happy to be able to present to you today, tonight, wherever you are, a new technology that I believe is going to change the way that we instrument and disinfect the root canal. And basically what I want to present to you is a new way that we can address the true anatomy of the root canal. And I'm going to go over the limitations of the files that we have presently and how these new series of technologies can help overcome these limitations. So basically, we're looking for success, obviously, and it's very important to understand what we're aiming for in terms of a definition of success. I was in academics for many, many years, and we directed our interest in endodontics in what I call academic success, and that's no detectable disease. In other words, if there's no radiolucency, which is a sign of apical periodontitis, we'd like to do the root canal if necessary, come back 5 to 10 years later and see no radiolucency present after that. If, of course, there is a radiolucency indicating that the tooth or the root canal is infected, then we'd like to instrument, disinfect, fill the root canal so that we lower the microbial count, and at our 5-year, 10-year follow-up x-ray, that sign of inflammation, the radiolucency, has disappeared. More recently, we've become much more interested in functionality or survivability. And this has been due a little bit to the implant revolution, if you will, where it's become very apparent that not only should you have no detectable disease, but of course the tooth has to survive in the mouth and function adequately, and this can happen in the presence of disease. So we want ideally to have a perfectly healthy periodontium and be able to leave as much natural tooth structure behind so that the tooth is as strong as possible and survives for the life of the patient. So I'm going to go straight into it. I've got a very limited time and give you our philosophy. When I say our philosophy, it's my philosophy. It's a philosophy accepted at the endodontic department at the University of Pennsylvania and many other departments, but it's by no means universally accepted throughout the world. And we have 4 basic treatment approaches where people may or may not agree. And I'm going to concentrate today on the newest change in our department, the anatomically directed instrumentation, as you see in yellow here. But I just want to spend 2 minutes on the rest, and I certainly will be available at Next Level Endodontics to answer in more detail on these points. First point is we want an adequate access cavity to allow, number one, to find all the canals, and number two, access to all the canals so that the canal can be cleaned adequately to the extent that the disease will heal. Now, this, of course, should be minimally large, but by no means too small in order not to be able to find the canals and clean them. So actually, this is going to be different for every practitioner. Ideally, you want as small an access as possible, but to allow the other two factors that I talked about. And some can do it with a small access cavity. Others need a larger access cavity. We, in our philosophy, fill to the cemento-dentinal junction. And this is where your apex locator indicates you've reached the end of the root canal. The cemento-dentinal junction is where the dentin ends, the end of the root canal, and the cementum begins, the beginning of the periodontal ligament. And because there's a cemental cap at the end of the root, this is always short of where the radiograph would say is the apex. So on average, we fill about 1 to 2 millimeters short of the radiographic apex in a vital tooth, and 0.5 to 1 millimeter short of the radiographic apex on a non-vital infected tooth. The reason there's a difference is because when there's a radiolucency, when there's apical periodontitis, some of the cementum at the end of the root is resorbed. You can't see it radiographically, but it makes the root appear shorter. So you're filling to the same point, but it looks different on the radiograph. I'll jump to 4 and tell you that because we are now going to change to anatomically directed instrumentation, we are going to clean the canal according to its anatomy and not create an artificial shape in this canal. That means we're going to save and strengthen the tooth with extra dentin, which means that your root canal filling should have the same aim and do the same thing. So we are going to talk for no more than 2, 3, 4 minutes about passive root filling with bioceramics root canal sealers, which allow you to fill with more sealer and less gutta percha than a lateral condensation or a vertical condensation technique, which are the techniques which are most popular today, where you're trying to stuff in as much gutta percha as possible in order to minimize the thickness of the traditional sealers, because these sealers will shrink and wash out. So let's go directly to the anatomically directed instrumentation. Now, what I'm alluding to already is that we're going to talk about instrumenting the root canal according to its natural diameter, natural shape, but we still need a minimum round apical size. Now, why I emphasize round apical size is because the traditional files that we have today, whether they're stainless steel files or nickel titanium files, they make a round shape. And that round shape is not the shape of the true anatomy. But we still need a minimum round shape, and I'll tell you what they are, what those sizes are in diameter, and also the reason for those minimal sizes. We also need a maximum taper. Now, I don't mean by maximum taper a big taper. What I'm going to say is your maximum taper should not be more than 0.04 or 4% taper. Anything more than that is unnecessary and unnecessarily weakens the root. So I'm going to go to the conclusion and then talk about the reasons for the conclusion. So in a small canal, and how I define a small canal, that would be the mesial of a lower molar, the buccals of an upper molar, or any root that contains more than one canal would be a small canal. And on these canals, we would say the minimum round apical size would be a size 30 or 35, depending on what irrigating needle you're using. And on a large canal, which would be a 1 canal distal on a lower molar, 1 canal palatal on an upper molar, a single rooted, single canal tooth, anterior teeth, canines, etc. The minimum would be size 40. And there's two reasons for these. And again, as I've said before, no more than an 0.4 taper or 4% taper. So in the small canal, it's a 30 or 35. In a big canal, a size 40. And the reason is twofold. We need to irrigate effectively. And we need also a stop for our root canal filling. Now, in order to irrigate effectively, we need to get our irrigating needle to the working length. I'm going to repeat that because this is extremely important. 90% of the microbes in an infected root canal are in the main canal, and they're swimming loosely. They're what we call planktonic microbes, bacteria. These, in theory, can be washed out with water. We don't use water, we use sodium hypochlorite, etc., etc. But in theory, you could remove 90% of the microbes if you just washed them out. The problem with a root canal is any root canal or any conical shaped thin tube, if you will, has air at the tip. That's what we call the vapor lock. And it is impossible to place your irrigating needle away from the last 3 or 4 millimeters and get enough irrigant into the last 3 or 4 millimeters. We have an illusion that we take it down with our fire. Yes, you take a little bit, but not enough. We have an illusion that all these irrigating machines can work like a power wash, and we stand, 3, 4, 5 millimeters away, and you push this irrigating solution into the apical part. This just does not work to the extent needed to wash out all these microbes. The only way to get rid of a vapor lock or air bubble is to physically displace it with something solid. And the way we recommend that you do that is to place your irrigating needle to the working length. Now, when we look at irrigating needles, up to a very short time ago, a 30 gauge needle was the smallest needle. Now we can get 31 gauge needles. So if you're using a 31 gauge needle, in order to get that to your working length, you need to have instrumented to a round size 30. And your 31 now, because it has no taper and it's slightly smaller than a 30, you can easily get that to your working length. If you're going to use a 30 gauge needle, then you have to instrument to a 35. That's why I said 30 or 35. Because a lot of people don't know that you can get a 31 gauge needle. If you've instrumented lower than a 30, you cannot irrigate effectively. If you've instrumented to 30, 35 and you're using an irrigating needle more than 30 or 31 gauge, you cannot irrigate effectively. So please, if you get nothing else out of this webinar, think about changing the sizes of your irrigating needle. Now, of course, in a big canal, we don't need such a small needle, but if we weren't going to use the same needle for big canals and small canals, the reason we need a size 40 is we need to prepare a seat for our gutta percha. Because when we place our gutta percha for the root canal filling, we want to stop at the cemento-dentinal junction. And the cemento-dentinal junction, the gutta percha needs a seat at this point. So how do you gain that seat? You have to instrument a round shape. Why round? Because your gutta percha is round, right? So you have to instrument a round shape slightly bigger than the minimum diameter of that root canal. In a small canal, on average, the minimum diameter is 0.25 millimeters, corresponding to a size 25. So by going to at least a 30, on average, you're going to create a seat where your gutta percha will not be able to slide through. In a big canal, on average, the minimum diameter is round size 35. So you'll go to a size 40. And again, on average, why I'm emphasizing on average, because sometimes, your clinical acumen tells you, in this case, it's I've got to go bigger. Then you're going to go to a 40, and you will have created that seat that is required. So the irrigation is very, very important, and we need to get the irrigant to the apical third, and the apical third, you can only get the irrigant there if there's no air bubble stopping the movement of the irrigant. So here's just a slide to show, number one, that if you're using a 30 gauge needle when this slide was made, the 30 was the smallest, you need a 35. We need a side vent needle for safety's sake, so you don't push irrigant through. And you also need a rubber stop on the irrigating needle to stop you from pushing the needle and, of course, then the irrigant through the apex when it's a bigger than 30 or 35 canal. So this, you just basically have to do the math, but we like to see studies. And this is a very nice study out of Switzerland by Zender. He was using a 30 gauge needle, which was the smallest needle at that time. And you see, he was looking to see how he could get the irrigant, the blue, down. And what he found was you need at least a 35 to get a 30 gauge needle down. Now that we have a 31 gauge needle available, we now can get to a 30-04. And then preparing for the root canal, as I said, we like to finish at the cemento-dentinal junction. Here is this cemental cap that I was talking about, and this is the reason why if you took a radiograph and you fill to the cemento-dentinal junction, it's going to appear short, and you want to go a little bit larger than the minimum diameter to allow a seat for your gutta percha, so that when your gutta percha is placed into the seat, the bioceramic sealer will be moved into the non-round parts of this root canal. And because the sealer is bioceramic and it does not shrink, and it expands slightly rather than shrink, and it does not wash out like traditional sealers, we can rely on more sealer and less gutta percha. In fact, we use the gutta percha as a hydraulic pump and not really as a maximal fill like the traditional root canal filling techniques of lateral condensation or vertical condensation. So again, a small canal, 0.25, so we need to go to a 30. A big canal, 0.35, so we need to go to a 40 in order to get this seat for the gutta percha. Now, maximum taper, as I said, is 0.04. Here is a study again that doesn't need to be done, but it's important that it is done. You'll notice that everything is done under water these days because hydrated teeth act completely different from dry teeth. And as you see, as the remaining dentin thickness, in other words, bigger taper, decreases, so the tooth is less strong. So the question is, how small can we make the taper and still have a biologically clean canal? And really, the coronal 2/3 of the tooth is easy to clean, both physically and with irrigation. So we'd like a minimum taper. And the taper we're suggesting today is 0.04, and it could be less. I'm treating more and more patients recently with O2 tapers. I'm not used to it anymore. It doesn't look the same. But as I get more calm and the look of this anatomical instrumentation becomes clearer to me, I'm becoming more and more comfortable with less taper. from a biological point of view, in the coronal 2/3, it's absolutely adequate. And then we use the 3D technology for the apical third. So let's quickly define the challenges that we have today. It's whether you're using stainless steel files or nickel titanium files, and then try to see how these new technological advances have attempted to solve these challenges. So as I've alluded to already, files, and I'm sure, I don't know how many people are on the webinar, but I'm sure you're probably using 10, 15 different file brands, whether it's stainless steel files, rotary files, but at the end of your instrumentation, unless you're using one of these brand new technologies, you are making a round shape. And that's basically screwing a round shape into a non-round canal. Because if you look at the studies, and this is a classical study by Frank Paquet, what he did was he used the 2506, which at that time was the most common size of file for finishing a root canal. And what they did was they used micro CTs to see how much wall they touched. And what they found was really quite amazing and very worrying, because 60 to 80% of the wall was untouched, not touched, untouched. And if you look at it, the red is the touched area, the green is the untouched area. So this is totally unacceptable, because number one, your irrigation doesn't go down, and number two, if you've got biofilm on the wall, the only way to remove the biofilm is to physically scrape it away from the wall. So this is very, very clear that this is unacceptable. Now, most endodontists today are into 3D CBCTs, and it's becoming now visible. Before, we didn't really see this because we took a periapical radiograph from the side, but it's becoming more and more visible that at no time going down a root is the root round. It's always a different shape. So this makes those results very much more easy to understand, because if you've got a canal that is not round, it's impossible really to clean it with a round file unless you go to the maximum diameter, and then you'll run out of root with the maximum diameter. Now here's a case that was shared to me by a colleague in Paris, France, Dr. Kayat, and you see a lower incisor which is instrumented quite large. Many people would say this is too large. It fails. Many people would say it fails because it was over-instrumented, and many, many different reasons. Now, Dr. Kayat did surgery on the case, and you actually see that in the mesiodistal dimension, as you see on the radiograph, it's very adequately instrumented. But in the buccolingual dimension, the part you don't see on the radiograph, not even a third of the canal is touched. And we see this doing surgery over and over and over again. This is one of our graduate students from last year at the University of Pennsylvania, lateral incisor, instrumented to size 50, tooth failed, thought that we couldn't go bigger than a 50, so better do surgery. You do the surgery, and again, exactly like the previous case, mesiodistally, it looks adequate. That's the angle you take the x-ray. But buccolingually, about a third of the canal is instrumented and cleaned, and 2/3 of the canal is still full of debris, microbes, etc., making it very easy to understand how this case failed. And many people have this illusion that within a round file, you can brush. And if you go to one side, you're going to clean one side of the canal. You go to the other side, you'll clean the other side of the canal. Well, that's true if the canal is absolutely perfectly straight. And no canal is absolutely perfectly straight. actually what happens is as you brush, the rest of the file gets pushed to the other side. And what you see is the round part moving from side to side. Here is a plastic 3D tooth. It's a true replication of a proper tooth. And you see here going from one side to the other, and at the curvature about 4 millimeters short of the end of the root. This is particularly dangerous because the file will tend to go to the inner curvature and if not strip perf, very severely weaken the root. One of the most underappreciated parts of instrumenting with a round file is dental debris accumulation. We appreciated this with stainless steel files because it was slow and we felt it, and because of that we created the step back technique. But the same thing happens with a rotary file, even if it's nickel titanium, and it happens at a larger speed. And what happens is the debris goes apically, and we try to avoid that. The debris goes coronally, and we're very happy about that. But also the debris goes into the irregularities in the non-round part of the canal. So actually what the file does is it encloses itself into a round shape by packing debris into all the non-round parts of the canal. Now that wouldn't be a particular problem if this debris was clean and our irrigant could get there. But of course this debris is very often filled with microbes, and is, by the way, a very good substrate for microbes if there were to be leakage. And also, if I come in later with an adjunct like ultrasonication, like Endovac, like all these machines that we buy to enhance our irrigation, this is going to be ineffective in this area because this packed dentin, packed debris, is just as dense, just as difficult to get into than the sound dentin around there. So actually what happens is the file very quickly fills the irregularities with debris. After the irregularities are filled, then pressure starts to build up in the root because the debris's got nowhere to go. And then you start to get these micro cracks and you get these predisposing factors for splitting the root. And this is very, very worrying, and it occurs more with one file systems or less file systems with bigger tapers because there is more debris produced and nowhere for the debris to go. So again, even if you fill it, as you've seen before, it's going to look fine on the radiograph in the mesiodistal dimension, but this, if filled with microbes, is always susceptible to failure. And again, you can see a nice example here of a lower molar with an isthmus. So we start off with a canal that is in no way round in any shape or form, but our instruments are round, so we make two round canals there. That's fine, but internally in the isthmus, we've packed debris in. Now, if I now come back with irrigants, ultrasonication, Endovac, whatever you may choose as your adjunct for irrigation, this is not going to allow, first of all, the irrigant to get into the isthmus, and also not going to allow movement between the canals through the isthmus. So this debris is a tremendous detriment to successful instrumentation, but more importantly, removing the debris after instrumentation. So the ultrasonic looks great on in a pool of water where it's moving perfectly, and you see how it's pushing the irrigant into all these places. Two things wrong with this picture from a practical point of view. Number one, where it's pushing them is filled with debris if you're using a round file. And secondly, the ultrasonic has to be completely loose and moving optimally in order to get this effect. And as you can see here, you need a lot of free space. So you need at least a 35 in order to have the ultrasonic tip loose. Now, around the curvature, or if you've instrumented less than a 35, your ultrasonic is not very effective. So let's look at a lower molar again. Here you have two what we consider small canals because the minimum diameter is small. So to you, it feels like a small canal. Generally, what happens with round files, you create a round shape and pack debris into the isthmus. What we'd like to do is clean much more anatomically. And if we don't have technology to reach physically through the entire isthmus, at least we must not pack debris. And then that'll allow our adjuncts to push the disinfectant through the isthmus, going from one canal to another in order to effectively disinfect this root canal. So if we look at a diagram of a typical canal, which is in no way round, up to this point, the most popular way to treat has been the minimum diameter. Very nice because it looks good on the X-ray and you can make fewer mistakes. Actually, if we want to get rid of all the biofilm and all the microbes, we have to go to the maximum diameter, which again is as bad or even worse because you run out of dentin either side, and you know, that's clinically unacceptable. So what we've been pushing at the University of Pennsylvania and other places I've been at is the maximal safe apical sizes. So we would go to much larger sizes than 25 at the apex, but even at these larger sizes, we acknowledged that number one, we weakened the root in the minimum diameter a little bit, and we could not clean maximally. So the best, of course, is to clean in a three-dimensional way. Clean the canal and only the canal, leave as much dentin as possible. And I feel that we are getting closer to this. Now, I'm going to add one slide here. And the reason I'm adding this slide is to show a CBCT. And because at this part of my lecture, very often I get the question, but we're getting such good results. If the round files are so bad, why are we getting 90–95% success from endodontics? Well, here's a periapical radiograph. Here are the same teeth with a three-dimensional CBCT. So the CBCT is actually showing us from a canal anatomy point of view that the canals are not round. That's very, very good. But also it's picking up disease that we don't pick up from a periapical radiograph. So this says to me that we need to clean better, because if you clean better in a three-dimensional way, even on a CBCT, these lesions are going to heal very, very well. So we are challenged more and more by better diagnostic tools, and we have to keep up with new technologies in order to clean better, because we still know that if we sterilize the root canal perfectly, whatever the diagnostic tool is, we're going to get very, very good success. All right, so let me talk about this new technology that allows us to clean better in a three-dimensional way. And this is two instruments. We've got the XP3D Shaper, which is actually an instrument that cuts dentin and favors the anatomic form of the root canal. And then we've got the Finisher, which does the rest of the job when the Shaper's capacity for expansion does not reach the full extent of the root canal. So this is based on a nickel titanium metal, and nickel titanium has two forms. You've got the austenite form, which is the stiffer form, and that's the form where there's shape memory. So if you take a nickel titanium alloy in the austenite form and bend it, it's going to be very flexible, but it comes back to its original shape. If you cool or stress physically this nickel titanium alloy, it loses its memory. So it becomes martensite, which is malleable. So if I would take a file in the austenite form and spray the file with endo ice or some coolant, I can then change it to the martensite form, which is the malleable form. So this is just an example how we can manipulate this. So let's think of this. This is a paper clip of nickel titanium at room temperature. Now the company has manipulated this so at room temperature it's at the martensite phase. So it's malleable, and when you bend it, it stays wherever you bent it. Now the water is body temperature. As soon as it reaches body temperature, it goes back to the austenite, which is its predetermined stiff phase. And this is a property that is true for all nickel titanium alloy. So with the technology I'm going to talk to you about, at room temperature, the instruments are in the martensite or malleable form, and they can be manipulated and bent to our requirements. But at body temperature, they go to the stiff form, where they are more effective in cutting the dentin or in moving within the dentin, as I'll show you. So let's start by showing you the shaper, and then we'll follow that by showing you the finisher, which have two different functions. So let's start with the shaper. The shaper blank, now it never really looks exactly like this, but the blank of the shaper has a round diameter at the tip of 0.3 millimeters. So that's equivalent to a round file of 30. And I hope you understand why we chose 0.3 millimeters or 30. That's because of the requirements for irrigation. That's the requirement to stop the gutta percha in a small canal. The blank has a taper of 0.01, 1%. So this file is extremely flexible because the metal mass stays very small. Okay? Now when it goes into body temperature or austenite, it gets this serpentine form, but stays at an 0.1 taper of the blank. So it stays very flexible, but it has the capacity of an 0.8 taper, right? So when it's in the austenite form, it goes to a 30 at the tip, an 0.8 taper if there's no resistance, but stays at the 0.1 taper for flexibility. Now remember, there are very few canals that are naturally this size. So basically what is going to happen in the canal is the file is going to squeeze down, work its way to a 30, and then based on how long you use it, it will overcome the resistance of the dentin to reach ultimately an 0.8. But we never wanted to reach an 0.8. So we use it for less time so that it doesn't go past an 0.4. I'll explain that a little bit better in a minute. So it comes out of the box looking a little bit like this at room temperature. When it goes to body temperature, it gets the stiffer serpentine shape. So it's 0.1, it gets a stiffer shape, and we don't allow it to go more than an 0.4 because we don't use it more than 10 strokes. If we used it way much more than that, it would slowly overcome the resistance of the dentin to get potentially to an 0.8 taper. So I'm going to quickly go through the advantages of this file in order to explain it a little bit better. File first of all, can be bent at room temperature because it's in the martensite form, and this facilitates it getting into any canal easily. Now, what I didn't mention up to this point, this file has this very, very special tip, which allows you to go from a glide path of a 1502 or a 1004 straight to the size 30 that is required for irrigation and for obturation. So let me explain this a little bit better. The tip at the end is very, very sharp and non-cutting. So this is your glide path part of the tip. So if you've got a 1502 or 1004, this instrument or this tip will follow that wherever you have your glide path. Within a quarter of a millimeter, it starts to cut at a specific angle, going from 0.15, that's the 15, and within 0.3 millimeters, it's got a 6 cutting edge, and it will be at a 30. So it's a quarter of a millimeter and approximately another quarter of a millimeter. So within half a millimeter, it's gone from a 15 to a 30. So this is going to allow you to go very, very quickly. So here you see it. The tip is loose. The rest of the active part is cutting from 15 to 30, and then you go to the 3001, which is the rest of the file. For sake of time, I'm going to skip over that video. And once you're at the 30, now you need to increase the taper. Right? So it's going to keep the flexibility, and you're going to increase the taper. Now, this is just to show you that you have a 30 tip but an 01 taper, a 30 tip but an 02 taper, and a 30 tip but an 04 taper, and the flexibility of the instrument is completely different. So what this file allows you to do is to keep the flexibility of the 01 but have the capacity of the 04. So here we're at a 3002, and now I want to go to a 3004. So all it requires is to go into, now here's your 3004, just showing you it doesn't go down because the taper is not good enough. So we go for 10 extra strokes, long strokes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Your 31 gauge needle easily goes to working length. And now, because the file has expanded, because it's austenite, your 3004 will now go to working length. So this is just a demonstration of how the file expands. If you would go longer, it could go potentially up to an 08. So this is important now. Those were just to show the booster tip and the expansion capacity. But the most important part here is it adapts to the original shape of the canal. So what you're going to see here, that if there is space, let's imagine this is a large canal, and if there's space, then the file is going to move laterally to a capacity of 1 millimeter, 100, but of course not round. It'll move to 100 laterally after it has reached a 0.3 mesiodistally. So if we watch that, you see that if there's space, it can move. If there's no space, it creates a taper. But if there is space, this is going to move laterally. So in this way, it's going to keep the original anatomy of that canal. So by using this, what we do is it selectively will go into the least resistant parts of the canal, keeping the original anatomy. So you can see that here. Here's a plastic block that's more anatomical, and you see in the large part of the canal, it expands. At the tip, it will be crimped down, and then the longer you use it, the more it's going to expand and widen the canal artificially, but we don't do that because we don't use it more than 10 strokes. So the idea is that this file will selectively enter into the non-resistant parts of the canal. And here you see that unlike the round canal, which bounces off, you're going to see here, or you should see here, it's not showing this video, the video shows the snake-like effect. Now another very, very important part here is because the core of the file is only an 01, even though you can expand to a 04, 06, 08, because the core is only an 01, there's a lot of space for debris, and there's no real need for the debris to be pushed into the irregularities. And that's very, very important. So if you use a one-file reciprocating system, and we use plastic blocks with light filters to show the pressure on the blocks, you can see tremendous pressure being built up in that plastic block. Even a round file, which is not reciprocating, creates some pressure. With this file, there's absolutely no color change, indicating absolutely no pressure. And the reason is the debris is loose within the file, within the canal, because there's space. The core of the file does not take up the whole canal, and it can be irrigated out very easily. So this is your typical round file picture, as I've shown you before. Here we see an experiment where there is no debris from this XP shaper. And that's extremely important because the adjunct I'll talk about in a minute will be able to work much more effectively. And here is a study showing how effective this is. The isthmus is not reached by this file, and the reason being that it cannot expand into the isthmus, but the isthmus is not packed with debris. But the main parts of the canal are almost entirely cleaned. Another canal. No debris. So what you see is almost 70% of the canal is touched. Remember before it was almost 80% was not touched? Here 70% of the canal is touched. And that includes the isthmus. If you take away the isthmus, about 89% is touched. So I'm just going to move through this quite quickly because I'm running out of time. And I'm going to then go to the main point where with the shaper, we change the equation. With a round file, the file gives an artificial shape to the canal. Now the canal gives the shape to the file. So this is a huge difference. And with one file, we can end up with 4 different sizes. So with this one file, the gutta percha required was different in each canal, but it was the file that followed the anatomic shape rather than the predetermined shape of a round file. Retreatment is also very effective because this catches the gutta percha and there's space for the gutta percha to be removed. All right, I'm going to spend just 5 or 10 minutes on the finisher, and then we'll have some questions. Now, as I said, the shaper will cut a shape favoring the true anatomy of the canal, but it has a reach of a maximum 1 millimeter. Now, in some canals, the buccolingual dimension, remember that lateral incisor I showed you, or the lower incisor that I showed you, they were way more than 1 millimeter in the buccolingual dimension. Internal resorption, other examples. So for those cases, we use the finisher. Now the finisher has the same way of being changed from martensite to austenite, but it's a blank of a 2500, making this very, very, very flexible. And in the martensite, you can straighten it, etc. But when it goes to austenite, it gets the sickle shape in the last 10 millimeters, which has a depth of 1.5 millimeter. And that sickle shape with a depth of 1.5 millimeter gives it a tremendous capacity for expansion, because the core is only a 25, but after it gets to the sickle shape, it has the capacity to expand to a 300, and if you squeeze the bulb, the tip can expand to a 600. If you squeeze the tip, the bulb can expand to a 600. And there's no real canals, even one with internal resorption can go to, is more than a 3 to 600. So this is what it looks like spinning, like a mixer in your kitchen. If you squeeze the bulb, the tip will expand. If you squeeze the tip, the bulb will expand. And here we have an example of an artificially bulbous, let's think of it as an internal resorption filled with cement. And what's happening is the bulb is contracting here, so the tip is expanding, the tip is contracting here, the bulb is expanding. It's making debris, much space for this debris, and you can now wash it all out, and the canal is clean. And basically, again, just to show what is happening here, this is Brazilian coffee. This is a friend of mine from Brazil, just showing that it's scraping the walls, putting the debris in solution, and then we come in after that and remove this with effective irrigation. So again, this is instrumented to a size 4004 with round files. You see what's left behind here. I guarantee if we took a radiograph, this would look very, very good in a mesodistal dimension. Now we've got two advantages of the finisher. One is it's going to get into all the indentations, and it's going to clean the rest of the debris. Scrape the walls of biofilm, allow you to irrigate this all out. The second advantage is, because it has a 2500 core, it is an extremely flexible and weak file. So it does all the scraping and cleaning without changing the original shape of the canal. So while you're removing the biofilm, while you're removing bacteria that is very difficult to get to, while this is creating turbulence in the irrigant so that it can move from one canal to another, etc., it is not really changing the shape of the canal. So this canal stays in its original shape, and because it stays in its original shape, it stays very, very strong. And I'll finish off here showing you an example. We have a lower canine, I think it is, a lower premolar, I think it is, obviously very, very wide buccolingually compared to mesodistally. We don't have much confidence that the shaper will reach the buccolingual dimension. So this is a perfect situation for the finisher, and you see how the finisher is moving in that buccolingual dimension, scraping the biofilm, creating a solution which can then be effectively irrigated, because the shaper created at least a 30 in the mesodistal dimension, allowing your irrigant to be effective to remove all the debris that is created by this scraping. Okay, thank you very much. I think I have to stop for questions, and I'll be very happy to answer any question that comes up, that I can answer, of course.
Well, that was excellent. Man, I haven't done root canals for a while, Dr. Trope, and so that's way different than I ever knew before. So it's amazing what you're able to show us these days, and I want to compliment you on the clearness of your of the talk plus the videos. What made it so easy to see what you were trying to show us. So that's wonderful.
Well, thank you. Maybe I should quit now.
Oh yeah, well, I tell you. So I have a question for you. I've got a couple from the audience. I have a question. You spent a lot of time in talking about making sure that the difference in physical characteristics of the files based on temperature. Do we need to worry about a tooth that's like on the screen right now, all isolated? It's kind of separated from the body. You have irrigant you're using. Do we need to heat up the irrigant or the lubricant to make sure that that file doesn't cool down and not be all the physical characteristics that make it so powerful?
No, actually, quite surprisingly, the temperature within the canal is body temperature. You can put a cold liquid in there, you can put a warm liquid in there. Within a couple of seconds, that liquid becomes the 37 degrees centigrade. So, and the file is, programmed, if you will, when it reaches body temperature, to go to the austenite shape. So, really, it's irrelevant what temperature you use outside the tooth. Inside the root is going to be body temperature.
Okay, good. So we don't have to worry about that. Okay, good, thanks. Now, if we have a molar with, say, 3 or 4 canals in it, we have to use 3 or 4 different XP shapers and finishers, right?
No, absolutely not. So one shaper will easily treat a 4-canaled molar. One shaper.
Oh.
Okay, so it's, the expansion and contraction is almost like a battery. It eventually runs out of spring, if you will, but it has way enough spring for a very tight 4-canaled molar. Now, if it were to be an anterior tooth where the tooth is naturally very big and there's a lot of air there, so the XP shaper expands without having to work to expand, you could probably go to 6, 8 anterior teeth with using just one XP shaper. And in addition to that, I use my shapers that I've used before, obviously after sterilization, for retreatment. So I didn't have time to talk about retreatment, but these are fantastic files to get out the core gutta percha. You just need to start with maybe an ultrasonic or another file and a little bit of a solvent, and this will very, very easily catch the core of gutta percha and pull it out. And that's done with a shaper that's already been used once before.
Okay.
It makes it very cost effective.
Yeah, that does sound efficient. So maybe I missed something, but there was a segment where you talked about making 10 strokes. Was that talking about the shapers, and that's a maximum you can do with the shapers, 10 strokes?
No. I'm glad you asked that question because I think I went over that part a little bit too quickly. So basically, let's assume that this is a narrow canal, a mesial of a lower molar, right? So we've got to do whatever we have to do in order to get a glide path. So you need a glide path of a 1502 or a 1004, and now you're ready for the shaper. If you have a 1502 or 1004, it should take you no more than 3 to 5 very long strokes. So you go in and disengage completely. Within 3 to 5 strokes, you should be at working length. So now you're at a 3002. But we want to expand this canal to a 3004. So with using 10 additional long strokes, that file is going to want to get to its natural 08. So it's going to overcome the resistance, and in 10 strokes generally, you are now at a 3004. And if you were to go longer and longer and longer, so the file expands, overcomes the resistance of the dentin, and can get to bigger tapers. Is that clear?
Yeah, that's helpful. Thanks. Okay, another question from the audience. Dr. Trope, the XP 3D shaper and finisher, up to what size does it enlarge the apical third?
Okay, well, it depends. You have to ask the tooth that, because it's going to enlarge it to the natural size of the tooth, unless the size is less than a 30. Okay, so if the size is less than 30, the shaper will create the 30 by using the booster tip, and etc. After that, because of its serpentine shape and the way it moves, it's going to tend to move in the natural and anatomic shape of the canal. So if I'm treating a young child, for example, with the distal of a lower molar, where this file can expand very easily without much resistance because the natural size at the apex is more than a 30, it's going to just move in its snake-like fashion and touch the walls in the natural anatomic shape of that canal and go to whatever size the canal is.
Okay. Well, then that leads nicely to the next question, which is if we're not creating a certain shape, a certain size with a specific file, we're getting the natural shape to the size the tooth is. How do you know which master cone you're going to use?
Very, very good question. And basically, after you've done your cleaning, we now have to fill. And the filling is done with gutta percha, and of course the gutta percha is round. So we have to, first of all, guesstimate which gutta percha is going to stop at the cemento-dentinal junction, right? So the way I do it, and now this is my preference, many people do it differently. I have a set of round files on my bracket table, and I start with a 3004, 3504, 4004, going all the way up to a 6004, right? And if my file, my shaper, had to work very hard to get to the working length, it took really 5 strokes, it probably means that this is a very small canal and I have created a 30. Now, I may not have created a perfect taper because of the anatomical shape of this canal. So what I do is, by hand, I take a 3004 round file, and I just go in and I twist it and rotate it so that takes off a little bit of undercut, a little bit of extra debris. So I know that if my 3004 goes to working length and stops nicely at working length, I know that my gutta percha is going to go easily to working length and stop. So basically, I'm synchronizing my file now to the gutta percha, knowing that the rest of the canal is anatomically clean. If, on the other hand, it took me 1 second to go down to my working length, I know that this is a naturally very big canal, right? So I'll do my cleaning and I'll let the file clean anatomically. And now I know that it's probably more than naturally a 30. So I'll say start with a 40 and test if it stops at my cemento-dentinal junction, which is my working length. If it stops there, slightly short, I'll rotate it a little bit and get a good stop. If it's very loose, I'll go to my 50. And in that way, I again synchronize the gutta percha with the final shape. And then, as I mentioned before, I'd like to do another webinar on root canal filling, because we use at Penn and the bioceramic sealer. The bioceramic sealer does not shrink, and the bioceramic sealer does not wash out. So we're quite comfortable that all this anatomic shape that we've cleaned will be filled with sealer, and we can use one gutta percha point not as a maximum filler, but just as a hydraulic pump to move the sealer into these anatomic shapes, and then we'll get a very adequate passive obturation, which again does not jeopardize the strength of the root and maximally strengthens the root.
Okay. So, you know, despite the magic of these shapers and finishers, you still have to think a little bit while you're doing root canals, it looks like.
Unfortunately.
So there's a question, does the XP shaper and finisher come in just one size then?
Yes, yes. So the finisher, I'm sorry. The shaper comes in one size. The finisher comes in two sizes. The standard one that I talked about is a 2500, but there is a 3000 which is made specifically for retreatment. Because when you do a retreatment, the gutta percha and the sealer, which is in the irregularities, is a little bit harder to scrape, and the 30 is a little bit stronger and tougher and scrapes more effectively, right? So there is a finisher R, which is a 3000, still very flexible, still works in your buccolingual dimension most of the time, but it has a little more bite to it when it's getting into gutta percha, sealer, etc. So that's the different size of the finisher.
Okay. Well, you did mention earlier that you can use a shaper that's been kind of run its course as a gutta percha removal tool there.
Yes, that's to remove the core gutta percha. But to remove the irregularities, the finisher is very, very effective.
I see. Okay. Well, that makes that clearer then too. Good. Now, do we have to worry about a cyclic fatigue limit for these files if we could sterilize them? I mean, do they lose some of their physical properties if they go through a sterilizer?
No.
Okay.
You know, they would optimally, you'd like to use them in one molar and throw them away, not because they're going to lose a little bit of elasticity to be able to expand, but they're very, very flexible files. So the only way they're going to break is if you catch them in the canal with tip lock. They're not going to break almost at all from cyclic fatigue. It's going to be from torsional fatigue. And that's the reason we use them at 800 to 1,000 RPM, because the higher speed you use them, the less chance the tip will catch, right, and lock. So we don't have to worry about cyclic fatigue because it's an 0.1 taper and it's very, very flexible. And the speed overcomes the possibility that it'll lock for torsional fatigue.
Okay. Now, a question about the irrigant. Do we have to activate the irrigant after XP Endo finisher files? And which one? Does Endo Activator work well?
We don't have to activate the irrigant because these files activate the irrigant on their own by causing a lot of turbulence. There's nothing wrong with using an ultrasonic. I don't like the Endo Activator. It's sonic and it's marginally effective. Ultrasonic is effective if it's loose in the canal. So I've got nothing against an additional clean with ultrasonic, but it's really not necessary. The finisher and the shaper activate the irrigant on their own.
Okay. So another question here, but I think the answer is obvious on that one. For retreatment, do you use just the shaper to scrape away that gutta percha and cement, or do you put irrigation in there as well?
Well, I use solvent and I use the shaper to take the main core of the gutta percha out, and then the finisher I use with irrigant.
Okay. All righty. Now, let me see. I have some other questions here. I guess we got another minute or so to go. Oh, here's one came in. Now that we've created a clean, anatomically correct canal space, how do you, can you talk through disinfecting and then drying prior to obturation? If you got, say, one of those spaces you showed, it has a bulb to it, which I thought was pretty fascinating, bulb and tip kind of a thing. How do you go about drying and disinfecting, making sure that's clean before you obturate?
Right. Well, the way I irrigate is I use sodium hypochlorite half strength. If you want to use higher strength, you can. I use sodium hypochlorite half strength throughout the instrumentation procedure, right? So when I'm using the shaper, I'm using sodium hypochlorite. And at the end, I will flood the canal with sodium hypochlorite and use the finisher for 20 seconds, irrigate, flood the canal again, another 20 seconds, irrigate, and then the last 20 seconds I use EDTA because the EDTA will tend to remove any smear layer or anything that you have there, and the finisher again. Then if it's a vital tooth, I will obturate and dry it with paper points. Now, the bioceramic sealer loves moisture. It requires moisture to set. So I want my paper point to be dry, but I'm not really worried if there's a little bit of moisture in an irregularity that I can't get to, because that will not affect the performance of the bioceramic sealer. Now, if it's an infected tooth, then I add as my last irrigant 2% chlorhexidine. Now, the 2% chlorhexidine has the ability to move through dentinal tubules and be a little more effective as a disinfectant. You don't need it in a vital tooth because a vital tooth is not infected. So we do it only with an infected tooth. And then after that, I just, wash it out, paper point dry, and go to the obturation. I've been very, very quick here because I only have an hour. I probably need double the amount of time. I'd just like to tell the audience, if you have any interest, just go to nextlevelendodontics.com, and there you can email me. We have courses. We can talk about this in much more detail.
Well, you anticipated my last question, which is going to be, how can these guys learn some more? So nextlevelendodontics.com.
Right. And that's, yeah.
Well, excellent. Well, Dr. Trope, thank you so much, and thank you everybody for your questions. We've run out of time, although it seems certainly we can go on and on, but they don't let us do that. So if we did not get to your question, we'll answer it after the webinar by email. Thank you all again for attending this webinar, and a special thank you to Dr. Trope and our sponsor for this webinar, Brasseler USA. Thank you. Have a great evening, everybody.